Okay, so good morning, everyone. I'm Rafael Oliveira, spine surgeon from Brazil, and currently working for the Pedicle in the global strategic marketing team. I have the pleasure to have Dr. Hartel here, and I'd like to thank AO for accepting this event, where we're going to have a live demonstration of MIS TLIF with navigation and visualization with Zeiss Kinevo. Dr. Hartel will start talking about his OR setup. Good morning, Dr. Hartel.
Good morning. Can you hear me? Yeah. Good morning, Rafael. Thank you for having me. It's a great pleasure.
Okay. So, Dr. Hartel, could you start explain to us how do you set up the OR for this procedure?
Sure. So I'll walk you through a typical setup for a minimally invasive transforaminal lumbar interbody fusion. And that's an operation, it's probably one of the most common fusion procedures that we do, obviously, especially in MIS, in kind of like the category of MIS surgeries, probably one of the most frequently done procedure. And it can be done, there are a million different ways of doing this, of course. So I like using navigation. Now we looked at our navigation numbers in our institution at New York Presbyterian, RealSpine, and Cornell in New York, and we navigate about 70–80% of our spine procedures, certainly the instrumented procedures. So navigation, we're very, very comfortable with navigation. We have a number of navigation systems available. So really all of us, we're 5 spine surgeons now in our group at Cornell, and all of us, we all navigate. So for us, the threshold to navigate a case is very low, and simply because we all think that it helps us with workflow, precision, safety, and it eliminates fluoroscopy. You don't have to wear lead, for example, and there's just so many, once you get used to it, there's so many advantages to using navigation.
Even for open surgeries, Dr. Hartel?
Yeah, for open and for MIS. Nice. Even ACDFs now, we navigate pretty much everything. The only thing we don't navigate is lateral surgery because there's so much motion when you put the cages in that it's not very accurate. For everything else, we navigate. Yeah, so navigation is number one. Then obviously the microscope, I personally think, and again, our group where I practice, we all use the microscope because it just helps you visualize, it's safer, you can see all the competent structures. And now the combination of navigation and microscope allows you to integrate both, and now we can actually use navigation or really augmented reality to show you all the particular landmarks for this procedure through the microscope. Now you could do the same thing with goggles, but if you use the goggles, you just don't see you lose the microsurgical ability. So the microscope allows you really to combine both. So what I'm going to show you is a TLIF on the right side at L4-5, and we're going to use the microscope navigation. In terms of the setup, the patient is positioned on the table, the legs are to my left, towards your right side, the head is over here. Because I use navigation, I always make sure that we tape the patient to the table, so there's very little motion. That helps you with accuracy because we rely on accuracy, or I rely in this case, on the accuracy of navigation because there's no fluoroscopy, right? So I want to make sure I really maximize the ability to maintain accuracy of navigation throughout the procedure, and taping the patient helps with that. And then in terms of the workflow, I like putting in the screws first because that is the most, in terms of accuracy, that's the more crucial part. So you do that in the beginning when the navigation is really accurate. And then the tubular decompression, the facetectomy, the cage placement, that's the second and third part of the procedure. And I'll walk you through that. Now, we set this up for augmented reality, and that's something that I presented at this meeting, and we just got that paper accepted in a journal. I don't use augmented reality for the screws, but I use it for the landmarks throughout the TLIF procedure. There are certain landmarks, obviously, that you use for the operation, bony landmarks, the pedicles, and then the disc space in between, the facet joint, the lamina, and those are the landmarks that are always the same for every TLIF procedure, and therefore I like to inject those into the microscope, and I'll show you how that works. Hopefully it'll work here the way that it works at home, but I think it will. So, and I put the microscope in here now, and if you can see that on your screen, the view of the microscope, if we can select that so the audience can see that, because can we do that? Can we show the audience? Yeah, you can see now we're looking through the microscope on the skin. I only do that because I want to show you the landmarks as they project already in the beginning of the case. So you can see the disc space here, you see the pedicles, and already now I could make skin incision because I know exactly where the landmarks are, right? But just wanted to demonstrate that. So, but we'll use freehand navigation for the pedicle screw part, and then we'll bring in the microscope for the decompression part. So the pointer is here. So first we select the entry point for the pedicle screws, and if you look at the screen, you have that there. So I'm looking at the sagittal spine here on the upper right corner. The projection of the sagittal spine, there's obviously a model, therefore it looks a little bit different from what you would see in the OR. And this would be then a typical entry point for the L5 pedicle screw. So I'll mark that on the skin here. And then for the L4 pedicle screw, I would pick this trajectory here. So that's right next to it. Now the skin incision is going, and I would do the same thing on the other side. So at the end we end up with 2 skin incisions. I'm only going to show you the right side. So now, obviously I connect the 2 dots, I make a skin incision. Now we're going to use the same skin incision not only for the pedicle screws but also for the tubular portion. And the tubular portion is going to be a little bit more medial. So I'll pick my skin incision a little bit more medial because I'm going to make 2 fascial incisions then. I'm going to make 1 fascial incision for the pedicle screw because I want that incision directly in the trajectory for the pedicle screw so I don't hit the fascia, it just increases the accuracy. And then I'm going to make a second fascial incision a little bit more medial for the tube placement, okay? And therefore I cheat a little bit with the skin incision towards the midline. Now we have the knife, and I have Andy here, right? Andy is kind enough to help us with some of the instruments that we need for the procedure. So I make a skin incision, maybe a little bit more medial from those 2 dots that I marked, and I make it a little bit bigger than I would in real life because of the plastic model here that's a little bit less malleable than a real patient. So I make the skin incision, I feel for the fascia, I make a fascial incision, and then I look for my entry point. Actually, the first thing I do is I want to confirm accuracy of the navigation. And the way to do that for MIS is or the way I do it is I look at the transverse process of one of the levels a little bit higher, and you can see I'm hitting the transverse process and I'm sliding up and down, and what I see and what I feel totally corresponds, and that tells me that this navigation setup here is really accurate. And then I go a little medial and I look for the trajectory of my pedicle screws. So who's from BrainLab? It's Taylor, right? Sorry. Now I can pick a pedicle screw size. Let's do a 645. So that would be a nice, and you can drop the screw now and find it later. I don't like doing that. I'll just, but for the size determination, this would be a nice time to do it. You can also do it preoperatively, obviously. You can look at your CT scan, MRI scan pre-op and pick your pedicle screws. You can also plan the trajectory like you would for robotic surgery. We just don't have to do that here because we use freehand navigation. So 6045 is going to be the size of the pedicle screw at L4. And then I go through the fascia again here, a little bit lower. I'll pick the L5 pedicle screw here, and that would be a nice trajectory and size for the L5 pedicle screw. So the same thing, 6045. So now we know the size and the length of the pedicle screw. Now we need the screws, right? So, and we use a Dupuis-Sinti screw that is designed in a way that it has a very aggressive screw tip, and it has integrated a K-wire that you can advance a few millimeters, and then once you don't need it anymore, you can pull it back again. And it's a navigated instrument. So it's a single stage navigated instrument. When we started navigating K-wire guided instruments, initially you would have to navigate the Jamshidi needle, the awl, the drill, everything. Now you only have to navigate one instrument. But did we calibrate that already? Yeah. So we calibrated it. There's an instrument that you use to calibrate it, and then you can put all your pedicle screws with the single pass Viper Prime pedicle screw. Okay. So now I know the size. We have the screws loaded. So I'm going to start putting in the screw, and I always start with the screw that's furthest away from the reference array. So that would be the L4 screw. I make sure that the BrainLab system can see it here. Now it can't. Is it 30? Yeah, maybe it's not calibrated. Huh? So let's calibrate it. Maybe we didn't do it. So this is the instrument that we use for calibration. And the process is pretty streamlined. And then the divot. If you have any questions, comments, just go ahead. We can make this very, very conversational.
One question, Dr. Harto.
Yeah.
Do you like drilling the entry points in MIS case for the screws?
It's not necessary with this system. Yeah. Yeah, it's not really necessary, and I'll show you. You can, and this is just to confirm the accuracy there. So this is nice and accurate. I'll give that back to you. You can, because this, when you put in the pedicles, you advance the K-wire. I don't know if you can see that where the camera is, but you can advance the K-wire, so the K-wire is actually sticking out. So that acts like as a docking point. So we'll go down through the fascia. I like to hold the screw right here at the skin edge. And then I find my trajectory for the pedicle screw, and then I hold it here. I confirm, gentle tap. See, you don't, because it's so aggressive, you don't really need it to drill an entry, but you can. If somebody has, if the bone is very, very hard, there's an instrument that we use, a navigated awl tip tap. That's very, very aggressive that you can also use. And we use that in very small pedicles or if the bone is very hard. Once you pass the pedicle, you retract the K-wire, and then you go down. If the patient has good bone here, so I like to take my hands off to confirm really accurate placement of the screw. So I'm very happy with what that looks like. And then I take the screw off, the holder off, and we'll load the second one, and we'll put in the L5 screw. So here you want to make sure that this is mobile. It can move a little bit. Great, thank you, Andy. So we'll advance the K-wire and put the L5 screw now. And that was too deep. So we go here, we find the entry point, a good trajectory. Always make sure that the navigation system can see the reference array. A gentle tap, and then and you start very, very slowly because you want to get that tactile feedback that the screw is really grabbing the bone, and then you go past the pedicle. Once you pass the pedicle, again you retract the K-wire, and you're good to go. You put the screw all the way down exactly where you want it. And again, we want to keep it a few millimeters proud so the screw head can still move. Maybe like this. This looks pretty good here. Maybe give me the empty screwdriver. I want to take these, because I want to take these out a little bit. Take these back so they're moving a little bit freer. So now we got the screws placed. I use monitoring. If there's a concern, you can stimulate the screws. But that's rarely, and then obviously at the end we get a spin. You have an fluorescent CT or some kind of imaging device. Yes, there's a question.
Thank you, Roger. I'd just like to ask you one question. Why you want to put your screw first and then do a laminectomy after that?
Yeah.
What is the reason?
You can do it either way. I like putting in the screws first because I want to have maximum accuracy in terms of navigation for that part. If I do because I do everything with navigation. Let's say if I did the laminectomy in the cage first, that would change the accuracy of the navigation, and putting in this, and then I would have to get another spin or re-register. So it's really for that reason. But you could, if you could do it the other way around too, it seems to, and the screws are never really in the way with the tube. You know, that's the other thing. So I've never seen that being a problem.
Do you think, Dr. Harter, do you think that using navigation to insert the screws helps you to have the screws in a better position so they do not get in your way when you are decompressing?
Yeah, I mean, yeah, because you can make sure you avoid the superior facet, for example. It's very accurate. That has been published. The accuracy is increased compared to freehand navigation compared to fluoroscopy. Yeah.
Great.
Yeah, you can maximize, and like I said, you can also pre-plan the screws, which is something that I don't typically do. So now the next thing, I told you I'm going to make a more medial incision now, same skin incision, but more medial incision in the fascia. And I'm planning that incision with navigation, right? So I want to end up here. That's the L4 lamina. And this is really where I want to end up. I want to dilate the lamina and then place that tubular retractor. I use a 22 millimeter tubular retractor. So I confirm the trajectory with navigation. I make the skin incision, the fascial incision, but here in that model that's not necessary now. And then I dilate. I feel for the landmarks. I can feel now the lamina here, that smooth edge of the lamina. I dilate, and you can see here, because the screws are mobile, they're not really in the way. There are other systems out there. I mean, there's so many systems out there, but this, for me, this works really well. So, and then obviously the more you dilate, the better it is in terms of getting rid of the muscle creep. Now you can already, so this would be a 40 millimeter tube. And the angle of the tube now is pretty much almost the same that I would use for an MIS laminectomy, even for a discectomy. I changed the trajectory later on. So I'm sure we're going to have a little bit of muscle creep here in the model, but that's, and then you really spend time dilating through the fascia, through the muscle. And then Andy, if I can ask you to release this and then attach the tube to the holder. That's great. Yeah. So I have a gentle, like medially angled, maybe 15, 20 degrees in the beginning, and then we'll confirm everything with navigation, so we're in good position. So now I want to know, where is the tube? Am I in the correct position? So I look at navigation. So I want to be in a position where I can do the facetectomy. The next part of the operation is going to be a facetectomy. And then the discectomy, cage, and then if there's stenosis, you can do an over-the-top decompression first or at the end. It's dealer's choice, really. But I want to make sure that in terms of the tube position now, the inferior edge of the tube is well below the disc space, which it is. The upper part is pretty high up. That's all the space I need cranially. Medially, we're in good position. And laterally, we're actually lateral to the facet joint. There's a 21 millimeter tubular retractor, right? And then throughout the procedure, if I have to modify the position, I can still do that. But I'm very happy so far with the position of the tube. No, we don't need that light source because we have the microscope. That's the beauty. So we have the microscope. So with the microscope, you then dial up the light source. Now, and I'm looking through the microscope, and I can see a few landmarks there, right? And I'm going to explain those landmarks to you. Maybe take out the facet joint, because I think that's a little bit irritating. Do we have a spine model here? We don't have a spine model, right? Yeah. So the first part of the TLIF procedure then, in terms of the facetectomy, the way I do it, again, there are a million different ways of doing it, but the way I like to do it, I like to identify the medial inferior border of the ipsilateral lamina and the pars, and then either with an osteotome or with a drill, you connect those two structures, and that will then allow you to remove the inferior articulating process of L4 in this case, and that opens up the facet joint. So I'm looking at the spine model now. So what we're going to identify here is for the, so camera's here. Yeah, it's a little bit hard, but anyway. But I'm identifying the inferior edge of the L4 lamina and the pars, and I connect those two structures, right? So those are two bony landmarks that we marked on the CT scan now, and we can visualize those with augmented reality. Now I use the pituitary here to remove some of the muscle. I would do this in a patient, I would do this with a bovie. I would cut this with a bovie. Here we do it with the pituitary. So I'm a little bit lateral with my tube. Actually can do this too. Do you see that blue structure? Can you see that? Can we see that on the screen?
Yeah.
Does that project? Oh, I can see it through the microscope. I don't know. So that's the inferior edge of the L4 lamina. That's really the structure that I want to get to. So if we can you loosen this again? I want to go a little bit more medial. Tighten it. And can we raise the table? Oh yeah, come a little higher. So I would, yeah, that's okay, thank you. So you want to make sure you're really in a comfortable position. And we got the suction, we got the drill. So now, so we use a drill that's slightly angled, so you can look around it through a tubular retractor. Now, the inferior edge of the lamina, can you see that? So we're on the right side. The inferior edge of the lamina is right here. The ligamentum flavum, you see a little bit, is down there. And I have a yellow spot here that I can see through the microscope. That's the pars. That's where I want to get to. So either with the osteotome or I like using the drill, I want to connect those bony landmarks. Sometimes I use the drill to get rid of the muscle. You can do that as long as there's no bleeding. But basically I drill through the lamina here, and I create that trough that eventually is going to connect the bony landmark, which is the inferior edge of the lamina, to the pars. So you can see here the ligamentum flavum is here. I'm touching the ligament with a drill. But now I don't really need to get fluoroscopy or any more, because I can see through the microscope with augmented reality. I can see my endpoint for the drilling, the pars. So now I'm gonna, can we angle this a little bit? So now I want to angle a little bit cranial. Tighten it. So I want to angle everything a little bit cranial so I have better access to those landmarks. With the pituitary, I'm going to take a little bit more soft tissue out. and to identify the lateral pars. If you don't have really any kind of imaging available, then there's a tendency to drill into the L4 pedicle or to stay too low, but hopefully with navigation you can avoid that. So I use a 2 millimeter or 3 millimeter Carrison now to complete that trough laterally, to disconnect the inferior edge of the facet. So I drill a little bit more here down to the ligament. So do you have some irrigation? So I drilled a little bit more. Thank you. That's it. So now with the Carrison, I can get underneath. And you can see now I go lateral with the Carrison, and then I take a bite and then I turn, and now that is the pars. So we disconnected the inferior articulating process, and we can see already now that's epidural fat. You can see the thecal sac, and you can see the exiting nerve root there coming out. So we're right under the L5 pedicle. I think that's irrigation, that's not CSF, I hope. Bone water. And then with the pituitary, now you got to release that facet a little bit more. Take some of the soft tissues out. Give that to you. So now we're looking at the facet joint. And can you see those? Oh, you can see that green spot, that yellow spot here. That's the pars. You know, that's where we wanted to drill to, and that's what we did. So again, augmented reality, if you have it, if it works, if you have it available, it really helps you identify bony landmarks and makes the procedure just a little bit smoother at this point. Or for teaching purposes, you know, it kind of really helps you then convey that to your residents and to your fellows. So I'm drilling a little bit into the facet joint here. So now here, that's the so let's see if that you can take that out with the pituitary. You take this bone, and then obviously we'll keep that bone because we want to use it for the interbody portion. We want to grind it up and then use it for the there we go, here it is. So that's the inferior articulating process of L4, and then there's still some bone fragments here. You want to get them all out. Be careful around the dura. Epidural fat, disc space, right? So let's try to get rid of some of that soft tissue here. Again, I would do this with bipolar or Bovie in a real case.
We have one question, Dr. Hart.
Yes. So that's kind of like what we call the Camden's triangle here.
Dr.
Yes.
Hartel, is it a
Yes, hey, Mike.
yeah? Is there a way to know where the pedicle is? I know you put the screws in, but let's say virtually, can we see the pedicle, or at least see where it is when we do the
Voila, voila, voila.
That's the pedicle, or that's
Taylor's going to show us the pedicle.
right? Because sometimes you don't want to go through the pedicle when you're doing the drilling.
Yeah, oops, it's a little faint here, but you can see, it's a little faint, but you can see the pedicle here.
All right. Okay.
That's the cranial pedicle, that's the L4 pedicle, and that's the L5 pedicle there. And that's, that's the parse, we mark the parse. Now we're using the brain, this software was made for brain tumors.
Okay.
So we're hoping to modify it for spine so those it looks a little bit more, reasonable. And then obviously you can use navigation. Now I'm putting in my pointer. If you switch to the navigation screen, so now we have the navigation. We're on the disc space, and the pedicle below, which is essentially the next landmark, would be right here. So that's what I would do in a real case. I want to find now the next landmark for me would be the caudal pedicle. Andy, if you open this up again, sorry. So we want to go a little caudal, tighten it. So the next landmark is, so now let's show me the L5 pedicle. Let's, so I can see that there in that weird color. And then I use a 3mm Kerrison to remove part of the lateral recess that's still there to really get down to the actual pedicle. And then I still have the superior articulating process there. If you take this back, so now I can confirm the pedicle with the ball tip. So I put the ball tip in, and I'm still, it's right there. I mean, it's kind of right there where the augmented reality says it is. And now I want to drill a trough right above the pedicle because I want to get rid of the superior articulating process. I want to harvest that so we have a little bit more bone for the disc space. So I always protect when I drill. I always protect with the suction. I go towards the dura. And then you got to lean your drill. I mean, every instrument, you lean it against the edge of the tube to stabilize it. And now I just make that cut right above the pedicle. And then with the Kerrison again, backhand or the assistant, you complete that cut, and then you can harvest the superior articulating process. Whoop, there we go. Now we take the pituitary. Pituitary assistant, here we go. So now we got enough bone to put into the disc space. And then the Kerrison again, if you have it. That's the ligament, PLL. So now again, I want to go flush against the pedicle. And you can see here that the augmented reality, if you see it on your screen, it's really very accurate. I mean, it's really, I'm hitting the pedicle exactly where that color indicates that we are at the pedicle. So that means then obviously that the disc space is right above. And then I want to take a little bit more bone here to facilitate then placement of the cage. Again, I protect the dura with my drill. I want to take this off without necessarily drilling into the pedicle. Give me the Kerrison again. But now we got to, I'm hitting the pedicle here. So I can't take any more bone. Irrigation. You notice there's no bleeding because nobody turned up the bleeding. They want to be nice. But there's a way with this model you can actually increase the bleeding to make it a little bit more realistic. Now the suction is plugged here, if you can address that. There was a, okay, here we go. So now we're going to suck out the liquid here. There's still a little bit of bone, pituitary. So now we have a nice image here of what we call the Camden's triangle, and you see he dialed up the bleeding. So we got the thecal sac here, medially, we got the pedicle here, the exiting nerve root, and that's our triangle. We can probably turn the bleeding down again now. So, that's, I've had enough. So now we want to work on our cage. So first thing I do again with navigation, I want to, and then now we have with augmented reality, we can actually visualize the disc space. You have that, right? I think I have to focus down a little bit to look at the disc space. Oh yeah. So now in yellow, if you can see it on your screen, you see that? There's actually the disc space. So, I confirm that. I like to confirm with navigation, because it's not only the disc space, but you also want to have your trajectory. You want to make sure once you put the cage in, that cage goes in a nice trajectory, so it ends up anteriorly and somewhat in the midline. And I think this would be a nice trajectory. So now, do I have an assistant who can hold the retractor? We have a nerve root retractor here somewhere. We had one here. Yeah, so I'll place that if you can stand here without obstructing the view. So, can you hold this here? So we're retracting the nerve root. We have a bayoneted knife. I use a 15-blade bayoneted knife. So now we cut into, and after that we're going to use the shavers. So I make an incision here into the disc space here. So we got a nice, generous disc space. It's not always as easy to cut into the disc. And then we use the knife back, watch out, yeah. So I use the shavers. Oh, great. That's a pretty big one, but that's okay. I'll position you a little bit better here. You see that? You hold it there. And then, because we're operating through a tube, I actually take the handle off. I just put in the shaver without the handle, because that way I can actually see where it goes. I'd use the mallet. It's here. I go in, 2-3 centimeters. You can. Okay, here. And then I attach the handle. And then make a gentle move. You don't want to cut into the bone. You want to make sure that disc space is really mobile, which it is. And then you start dilating and shaving. Now, I like to put the pointer back in at this point, just to confirm that I'm really in the disc space. So I think you would have to, I'll hold it for you if you just step back for a second. See, now I want to confirm I'm really in the disc space. Again, we don't have fluoroscopy, so you got to be really, you can hold it again. We don't, the next size up. We don't have fluoroscopy, so you really got to be very, very meticulous, but it works nicely. Actually, you know what, I think we don't need it. We did a nice facetectomy. I think we're actually fine without having to retract anything. So mallet. And then handle. So when you put the handle on, you want to make sure you don't push the instrument too deep, of course. You've got to be careful. And then we prepare the end plates, do the discectomy. And now, if you give me a kerosene, I'll take a little bit of this with a kerosene to create a nice window. So I like to really look down into the disc space. I need somebody here. You clean my instruments here, sorry. So, and now we use, I like to use those 90-degree down angle curettes for the disc prep. And And it's nice to do that with a little bit of visualization, and then it's really tactile feedback. So here you got to be careful because you don't want to cut into the bone, but I can feel the end plates. That feels really good. And then cranially also, I can feel the end plates. Look at that yellow outline of the disc space. That's really accurate. It's really nice. It kind of helps me stay in the right trajectory. So I'm, removing end plate, removing disc material pituitary. Maybe focus in a little bit more. So I always protect the dura with the suction here. And then, this is really probably the longest part of the procedure is the disc prep, right? Because for MIS TLIF, the whole success of the operation depends on a good fusion. And the only way to get that is really through the disc space. So that's why we really spend a lot of time with the discectomy and preparation of those end plates. So that looks now. Now there's an instrument here that Zeiss has. That's an exoscope. And you can now, for example, you can go into your disc space and inspect the, you can inspect the end plates, right? So I did a good, you see I'm caudally here, I'm on the end plate here, there's still some disc material left. I think the cranial, the lower L4 end plate, I can do probably better job, but then here, there's end plate there, so it looks pretty good, but I think we can do a little bit more work. Pituitary. Why don't I use that at home? I don't have that. That exoscope, I don't have that.
You have that?
I do?
Yeah.
Nobody told me. That's great. Okay, I use the kerosene now. Just create a bigger window. Do you have the, what shaver was the last one I used? Yeah, all right, let's get a 9. So we use one more shaver. I think the cage is a 9mm cage, mallet. So we'll go in, handle. Yeah. Yeah. So no, yeah, okay, you guys are bored watching me do a disc prep. All right, so I actually don't use a trial. So we navigate the cage. We use a 9mm cage, and again, we don't really need to retract the dura here because we got a nice exposure. So we go in with the navigated cage. Hold on like this, right? See that here? And then typically take the microscope out. Obviously watch your monitoring, but this is a nice trajectory for the cage. That image is flipped upside down there, that lower one. That's okay. Yeah, that's good. Yeah, so now we insert the cage here. Oh, now it's hitting. Now we lost the navigation because the arm is in the way. So we can just disconnect it. Just disconnect it. Then the navigation is back, and that's it. So now that's a nice placement. And how do we disconnect this here? Like that. So that's it. So now we can bring the microscope back in. Take a look. So now you see, through the microscope, you see the disc. think we didn't balance the scope. That's another issue. But here you see the cage. You have a ball tip. I can walk you around here. So we got the fecal sac here. The cage is inside. And now you can backfill the cage with bone graft. I mean, I would have, what I didn't do here is I would put bone chips anteriorly to the cage from the facet joint. I didn't do that here. And then you can backfill the cage with bone graft material as well, and make sure that that exiting nerve root is completely decompressed, which it is. Yeah, now we're done. So here, you can see that exiting nerve root here is nicely decompressed. Make sure there are no bone chips there, pushing on it, and then you got hemostasis, take the retractor out, pass your rod, and then obviously you got to put screws on the other side. But we did that already usually. So that's really the MIS TLIF, the way I do it, and some of my partners do it. Again, I like putting in the screws first because the accuracy is greater. I like to rely on navigation. You got to modify your workflow a little bit. But I've never had, maybe there's sometimes a case where you have to re-register, but I've never had to bring in fluoroscopy. Nobody wears lead. It's a very, very elegant and very streamlined workflow. Okay. Any questions?
Yeah, one question, Dr. Harto. Do you think that using navigation increased your ability to have a better positioning for the cage? Because we know that it's important to the cage be anterior, so we do not have like a very kyphotic situation for the air.
Absolutely, and that's why I use the pointer always to confirm the trajectory of the tube, because the trajectory of your tube is going to determine also the trajectory of your cage, because you do everything so when you do the discectomy, the tube is going to determine how far medial, how far lateral, and that you can modify that with navigation. So yeah, absolutely.
So it's important to have in mind since the beginning the way where you want to go, the way you want to be.
Yeah,
Great.
Absolutely, yeah.
Nice. Any more questions from the audience? And Dr. Hart, we know that many surgeons may not do the closure, and the staff do the closure. Do you have some orientations? Because as we talk about MIS surgery, we really think about less tissue damage for the patient. So tissue management is really important. Do you have any tips about closure to avoid complications?
Yeah, so it's very important to close the fascia very carefully. And here I told you that we have two fascial incisions. We have one more medial for the tube, for the facetectomy, and one more lateral for the pedicle screws. So both openings have to be closed. And that's can be a little bit tricky because sometimes that can be very deep inside, but it's really important to get a nice fascial closure. And then higher up and under the skin, it's really the choice of the patient and the surgeon. You can use staples, subcuticular closure, but I think it's very important to get good fascial closure.
Okay, thank you. Any other questions from the audience? Okay.
All right.
All right.
Well,
so I'd like to thank Dr. Harto for this amazing demonstration. I think it was really clear, your workflow and all the streamlined process you have. Thanks so much for sharing your knowledge with us this morning.
Well, thank you, Rafael. Thanks to the AO for putting this on. Thanks for watching. All right.
You could keep